name's Morgan. I'm going to be your nurse practitioner today. What brings you in?
I'm just here for an annual assessment.
Okay, we're going to go over 3 assessments. We're going to do a neurological assessment, a respiratory and cardiac assessment, and an abdominal assessment.
Okay.
Okay, can you start by telling me your name and date of birth?
Samantha Morrow, 11990.
Okay, good. And do you know the date today?
April 5th, 2018.
All right, do you know who the president is?
Donald Trump.
Okay. Now we're going to go into your cranial nerves. Since you previously just had your visual acuity attested, your 20/20 vision, we're going to skip that. Now we're going to start by checking your pupil reaction. Okay. The other side. Good. All right. Now I'm going to check your eye movement. If you could follow my finger with just your eyes. Good. All right. Now I'm going to ask you to smile. Puff out your cheeks, raise your eyebrows, all right, and stick out your tongue, and move it from side to side. Good, and now I would normally check your gag reflex by asking you to open your mouth. All right, now we're going to check your facial sensations. It's either going to be sharp, dull, or soft, so I'm going to have you close your eyes.
Okay. Soft. Soft. Dull. Dull. Sharp. Sharp.
Okay, good. Now we're going to check your neck and shoulder strength. If you could just lift your shoulders up here. Okay, good. And put your head against my hand. All right, if you could squeeze my fingers. Good. Now sit back a little bit. I'm just going to check your leg strength. Okay, pull up towards me and push down. Good. You can sit up at the edge here. Now I'm going to ask you to touch your finger to your nose with your eyes closed. And the other side. Good. Now if you put your heel on your opposite knee and rub down your shin and do it with the other leg. Okay, perfect. Now I'm going to have you walk just in a straight line here. And back towards me. Okay, and if you put your arms out with your hands up and keep your eyes closed, I'm going to check for a drift. Okay, good. You can sit back down here. Now we're going to check your sensations, similar as we did to your face, on your arms and your legs. All right, it's either going to be sharp, dull, or soft. Now close your eyes.
Soft. Soft. Dull. Dull. Sharp. Sharp.
Okay, now we're going to go to your legs.
Soft. Soft. Dull. Dull. Sharp. Sharp.
Okay, perfect. Now I'm going to put 2 different objects in one of your hands, and I want you to close your eyes and tell me what the object is.
Okay. A paperclip.
Okay, and your other hand.
A coin.
Okay, good. And that completes your neurological assessment. Okay, now we're going to continue with your cardiac and respiratory assessment. Your vital signs were reviewed, and they were all within normal limits. Do you have any shortness of breath?
No.
Any heart palpitations?
No.
Any chest pain?
No.
Do you smoke at all?
No.
Okay, good. Now I'm just going to start by inspecting your chest. In a normal clinical setting, we would have you exposed, but for now, I'll just have you take your jacket off.
Okay.
All right, I'm going to come around the back here and look for symmetry in our chest expansion, so take a deep breath. Okay, good. Now we're going to check for tactile fremitus, so when you feel my hands on your back, just say 99.
99. 99. 99.
Okay. And 2 more times.
99. 99.
Okay, normal tactile fremitus expected. Now we're going to go to percussion. Okay, we'll go to the back here. Okay, all areas are resident. Now I'm going to listen to your lung sound. Okay, take a normal deep breath. deep breath. Okay, all areas in the front are clear. Now we're going to check for bronchophony. So if you could say the word 99 as I move my stethoscope.
99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
Okay, all done.
Okay.
That was negative. So now we're going to continue with the cardiac assessment. So I'm going to take a look at your hands and check for capillary refill and edema. Okay, and I repeat. No edema, and your capillary refill is less than 3 seconds. So now I'm going to palpate your arteries here. We'll start with your carotid. Okay, look at your brachial. Okay, if you can lay back, we'll start with your femoral. Your popliteal. Okay, and your pedal pulses. All pulses are palpable. Alright, so now if you can lay back, I'm going to check your PMI. Alright, mid-clavicular space, or line, 5th intercostal space. Okay, and if you could lay on your left side here. Okay, and if you lay back, I'm going to listen to your heart sounds. Okay, no murmurs or extra sounds. Now I'm going to listen to your abdominal aorta. And your renal arteries. And your iliac arteries. And your femoral artery. Okay, no bruits were heard. You can sit up. And that will complete your cardiac assessment. Okay, now we're going to continue with the abdominal exam. Have you had any belly pain, any nausea or vomiting,
No,
any constipation or diarrhea?
no.
Okay, when was your last bowel movement?
This morning.
Okay, I'm going to have you lay back and just inspect your abdomen here. I'll have you expose your stomach. There you go. Her abdomen appears flat. It's not distended. So I'm going to take a look. Take a listen here. Okay, we're auscultating for bowel sounds in all 4 quadrants. And they're normoactive. Okay, now I'm going to continue with percussing your abdomen here. You'll feel me tapping on your belly. Okay, your abdomen's generally tympanic, so now I'm going to percuss your spleen, which is dull sounding. And we're going to percuss the liver span. Okay, which is normal. Now I'm going to palpate her abdomen for any masses or tenderness. Do you have any pain in your stomach?
No.
Okay. I'm going to palpate for the spleen, which is not palpable. Okay, we'll palpate for the liver. Okay, now I'm going to palpate for your kidneys, which are also not palpable. Okay, if you can sit up here, I'm going to check your back for any CVA tenderness. Let me know if you have any pain.
Nope.
No? Okay, well that completes the abdominal portion of your exam. Now I'm going to begin a discussion about the male prostate and rectal exam. First, you want to gain a health history prior to starting the examination on any pertinent information. Make the patient feel comfortable enough because it is a sensitive area to discuss. Be sure to explain to the patient what you're doing and what they can expect for the procedure throughout the exam so they feel as comfortable as possible. Gown the patient appropriately, exposing only the genitalia and inguinal areas. Gloves should be worn throughout the exam and hand hygiene should be used as appropriately. You want to start by inspecting the penis with the skin. Inspect both the ventral and dorsal surfaces and the base of the penis for any excoriations or inflammations. Next, you would inspect the foreskin. If present, retract or ask the patient to retract the foreskin. This step is essential for detection of cankers and carcinoma. Smegma, a cheesy whitish material, frequently accumulates under the foreskin, which is normal. So make the patient feel comfortable and let them know that this can be normal. Inspect the glands next. Look for any ulcers, scars, nodules, or inflammation that is present. Inspect the location of the urethral meatus. Hypospadias is a congenital ventral displacement of the meatus on the penis. Compress the glands gently between your index finger above your finger and your thumb, and note any discharge. Normally there is none. If discharge is noted, have a culture material present to collect the discharge. Next, you're going to want to palpate the shaft of the penis between your thumb and your first two fingers, noting any indurations or abnormalities, including any tenderness that the patient may have. If you retracted the foreskin during this portion of the exam, replace it before proceeding on to the scrotal exam. Induration along the ventral surface of the penis suggests a urethral constriction or carcinoma, and tenderness suggests periurethral inflammation from a urethral stricture. Now to the scrotum. Inspect the skin by lifting up the scrotum so that you can inspect the posterior surface. Note any lesions or scars. Also note the pubic hair distribution. Inspection may reveal scrotal nevi, hemangiomas, as well as STIs, including condylomas or ulcers from herpes. Inspect the scrotal contours for any swelling, lumps, veins, bulging masses, or asymmetry of the left and right hemiscrotum. A poorly developed scrotum on one or both sides suggests cryptorchidism. Inspect the inguinal areas and note any erythema, excoriation, and visible adenopathy. Erythema and minor excoriation can point to a fungal infection, which is not common in this moist area. Palpate each testes and epididymis between your thumb and your first two fingers individually. This should be firm, but not hard, descending, symmetric, non-tender, and without any masses. Tender, painful scrotum swelling is present in acute epididymitis, acute orchitis, torsion of the spermatic cord, or a strangulated inguinal hernia. For each testis, assess the size, shape, consistency, and tenderness. Pressure on the testes normally produces a deep visceral pain, but any painless nodules noted on the testes raises the possibility of testicular cancer, and further examination should be warranted. Palpate each spermatic cord between your thumb and fingers from the epididymis to the external inguinal ring. Note any nodules or swelling. Swelling in the scrotum can be evaluated by darkening the room and shining a bright light from behind the scrotum. After the physical exam of the male genitalia is complete, you want to educate your patient on the importance of performing a self-examination once a month. Explain to your patient that it is normal for one testicle to be slightly larger than the other and for one to possibly hang lower than the other. Encourage them to bring any questions to your attention as necessary. Now to the rectal exam. Again, you want to make sure you gain a health history prior to the examination and make the patient feel comfortable explaining any information or concerns that they may have. Be sure to explain to the patient what you are doing and what they can expect during the exam. Position the patient in a left side lying position to allow for good visualization of the perianal and sacrococcygeal areas. Drape the patient appropriately and adjust the light to ensure good visualization. Glove your hands and spread the buttocks apart. Inspect the sacrococcygeal area and perianal areas for any lumps, ulcers, inflammation, rashes, or excoriations. Adult perianal skin is normally more pigmented and somewhat coarser than the skin over the buttocks. Palpate any abnormal areas, noting lumps or tenderness. Examine the anus, rectum. Lubricate your gloved index finger and be sure to explain to the patient that they may feel the urge to move their bowels during this procedure, but that will not occur. Ask the patient to bear down as if they are having a bowel movement and inspect the anus, noting any lesions. While the patient is bearing down, place the pad of your gloved and lubricated index finger over the anus. As the sphincter relaxes, gently insert your fingertip into the anal canal in the direction pointing towards the umbilicus. If the sphincter tightens, reassure the patient as they can relax and proceed with the exam. Do not apply any unnecessary force. If the patient feels severe tenderness or pain, place your fingers on both sides of the anus. Gently spread the orifice and ask the patient to bear down. If then you're able to proceed without discomfort, notice the tone of the anal sphincter. Normally, the muscles close snugly around your finger. Initially, resting tone reflects the integrity of the internal anal sphincter. To check your external sphincter tone, ask the patient to squeeze your finger with the rectal muscles. Be sure to note any tenderness, induration, irregularities, or nodules present. Next, palpate the rectal surface by inserting your finger into the rectum as far as possible. Rotate your hand clockwise to palpate as much of the rectal surface as possible on the patient's right side, then counterclockwise to palpate the surface posterior and on the patient's left side. Again, be sure to note any indurations or irregularities. To bring a possible lesion into reach, take your finger off the rectal surface and ask the patient to bear down and then palpate again. In a male, this is when you would assess the prostate. Rotate your hand further counterclockwise so that your finger can examine the posterior surface of the prostate gland. If you turn your body slightly away from the patient, you can feel this area more easily. Be sure to inform the patient that examining the prostate gland may prompt an urge to urinate. Sweep your finger carefully over the prostate gland, identifying its lateral grooves and the groove of the median sulcus between them. Note the size, shape, mobility, and consistency of the prostate, and identify any nodules or tenderness that the patient may have. A normal prostate is rubbery and non-tender. If possible, extend your finger above the prostate to the region of the seminal vesicles and the peritoneal cavity and sweep the anterior wall, noting any nodules or tenderness that the patient could have in this area. Gently withdraw your finger and wipe the anus or provide tissues to the glove. Note any appearance of fecal matter on your glove. That completes this exam. Allow the patient to redress and feel comfortable and let them ask any questions that they may have regarding their exam.